Hi everyone, I'm Glenn Galton, and it's really terrific on behalf of the Center for Global Health to welcome all of you here this afternoon. And again, a great pleasure to once again welcome Dr. Ellis Owusu-Dabo to Penn. And of course, Ellis spoke. I got it pretty good. Yeah, I know. I'm not very good with phonetics. So, Ellis, of course, spoke earlier today on the topic of social media and drug resistance to TB. Really a fascinating guy with wide-ranging interests. Ellis is the director of the Kumasi Center for Collaborative Research in Tropical Medicine at the Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. He's trained both in medicine and in epidemiology and in public health. And as I mentioned, his interests are, at one level broad, but also focused in their application in the areas of biomarker development, and that was a big part of the TB work that he talked about earlier today. And more to the subject of this evening in the topics of population genetics and the pathogenesis of type 2 diabetes, which is a growing burden in Ghana and throughout the world, as we all know. So this evening is really a blend of these many topics. And the title of the talk, you see it here, The New Menace of Sub-Saharan Africa, Dealing with the Dual Burden of Communicable and Non-Communicable Disease. Ellis?
Thank you, Dr. Okay. So good evening. Thank you for coming. It's been a terrific last couple of 6-7 hours or so, and engaging with you and talking with friends, some of whom I haven't seen in years, some of whom failed to visit me in Ghana 2 years ago because of Ebola. Okay, but it's good to see you all, and thank you for coming. So this evening, I just want to have a little bit of a dialogue with you and share with you some of the thoughts and concerns we have in an emerging menace, which is type 2 diabetes in Africa. This will be the outline of my presentation. First, I'll talk about the burden. I'll talk about how it's distributed in Africa, and I'll look at Ghana specifically. And I'll talk about how we're addressing the issues. I will share some results with you from a study that is a multinational, multi-center study that we conducted a couple of years back by way of action that is being taken in the evidence that we want to provide. And then finally, I'll give you a take-home message which will help you to remember this phase. Okay. So a couple of facts which we all are aware, and these are from the Global Health Report. And I'd like to reiterate these points that Africa's typical health burden, as we all are aware, are usually related to child survival, maternal health, diarrheal diseases, upper respiratory tract infections. We're not yet out of the woods yet with malaria, tuberculosis, and HIV/AIDS. These are a fact. And coupled with that, we have issues related to neglected tropical diseases. There seem to be some realistic declines in targets as far as child survival is concerned, particularly those in relation to malaria, mother-to-child transmission of HIV/AIDS. We've seen some significant improvements there, but there are issues. I intentionally decided to keep each of them as one, and that's because it's important to remember that. There is an established link between diabetes and tuberculosis. There's so many publications, Dubranesque, WHO, systematic reviews on the use of on type 2 diabetes and tuberculosis, not so much as in just the disease and its pathogenicity, but also in the use of certain medications for tuberculosis, which are a risk factor for type 2 diabetes. So, for example, in the African region, where you have a prevalence of TB of around 356 per 100,000 of the population, that is a major risk for type 2 diabetes. It's a major risk. So the African region, the WHO Afro region, has the highest population prevalence of type 2 of tuberculosis. These again are established. Diabetes and tuberculosis. If somebody has tuberculosis, he has a 3 to 4 chance of developing type 2 diabetes and vice versa. Actually, more the former. The use of ARTs, such as, for example, the nucleoside reverse transcriptase inhibitors and protease inhibitors, are linked with metabolic syndrome. It's an established fact. And therefore, when you have a continent which is ridden with HIV/AIDS and people are on these nucleosides, inhibitors, and so on, the risk of metabolic syndrome, which could be precursors of type 2 diabetes, are a major concern. And that is something that we're dealing with. I mean, fortunately, Ghana does not have a problem with HIV/AIDS in terms of the total numbers. Our point prevalence is still under 1%. It has remained like this for the last 3 years. We started off at around about 1.8 and continued to 3.6 was our highest ever. And then now we are somewhere 0.8% of the population. So, but cumulatively, if people are going to be on these ARTs, then the risk of metabolic syndrome is much higher. And if you're looking at areas like South Africa, where in some places you can have HIV prevalence of about 40 to 50% of the population, that is a major risk for a country or a continent which is not out of the woods yet with communicable diseases to be handling the issues of metabolic syndrome, which could be precursors of type 2 diabetes and other related non-communicable diseases. That is significant concern. There are established links between urbanization and NCDs. And I have to say to you that Sub-Saharan Africa in the last 10 years has seen per capita growth highest in the world. And therefore, there are significant growth in urbanization. The city where I'm based, for example, is one of the fastest growing cities in West Africa. Megan did her MPH field work and published a paper that looked at the effect of urbanization on diet. And we are aware that in many of these places, globalization is caught up with the people, and therefore diet is changing. And so is activity levels of people, and the fact that you're resorting to less physical activity, and the use of vehicles and other things. The effect of travel and copy paste, it could be anything. I mean, in terms of having to sit down long hours and behind a television and keeping your activity low to the sort of beggar kings. I mean, 5 years ago we didn't have any fast foods in Accra. But at the moment, we have several. We have KFCs, and we're seeing McDonald's building, and they are coming. And these are a fact. And in many places in Africa, I mean, when you talk about a place like South Africa, we don't tend to count South Africa as part of, because of many reasons. But in many places like West Africa, East Africa, and other places, this is happening. Why am I telling you all of this? We know that urbanization in Sub-Saharan Africa, as in other less developed parts of the world, is strongly associated with increased levels of obesity. And these are, and of course, diabetes and cardiovascular disease. So it's an important thing for us to do. At the last check, where's the pointer? Okay, which is the pointer? Do you have the beamer? Okay, thank you. So the last stats, again, this is from WHO Afro region. As you would see, the burden of disease profile within the African region, HIV/AIDS occupies 21%. So you still have HIV/AIDS, you have malaria, you have lower respiratory tract infections, and of course, tuberculosis, measles, and diarrheal diseases put together, they're still there. But of course, all other causes, I'll be giving you a bit more detail about this. And here I have to say that a lot of these, significant proportion of the 40% that we have here, is contributed by non-communicable disease. So while we have all of these still with us, okay, we still are having these emerging non-communicable diseases with us. So what is the current situation, and what do these imply by way of, so again, Africa has made significant progress in reducing child mortality, and that is a fact. From the MDGs, as well as the current Sustainable Development Goals, have been significant progress that have been made. Mortality from vaccine-preventable disease particularly has reduced across the board, and that is also, again, a fact from the Global Health Report. Child and maternal health has improved significantly since 1990. Again, that is a fact. But although declining, communicable diseases, newborn, nutritional, and maternal health causes, again, as far as lower respiratory tract infections are concerned, they still are top drivers of health loss within Africa. Between 1990 and 2010, disease burden from non-communicable causes increased, particularly those related to cerebrovascular accidents, depression, diabetes, and ischemic heart disease, particularly among upper middle income countries in the region. I mentioned to Glenn whilst we were having a chat this afternoon that road traffic accidents is a big problem. Injuries, and particularly in relation to road traffic accidents, and of course interpersonal violence, have increased in many countries. And to cite the instance of Democratic Republic of Congo and Lesotho, these are two countries that are noted to have significant increase in these. And of course, alcohol use, high blood pressure, and smoking were also top contributors to health loss in many countries in Sub-Saharan Africa. As far as Ghana is concerned, smoking is not a significant problem. We've had less than 4% of the population smoking all the time. And of course, even in women, it's much less. I mean, it's definitely less than 1% of the female population smoke. So what do these mean? And of course, here I attempt to show you the mortality rates per 100,000 as a result of non-communicable diseases. And if you look at Ghana, somewhere there, so it's somewhere within that range. I apologize for the blur picture here, but for those of you who are wondering, Ghana sits right there between La Côte d'Ivoire and Togo. And of course, in the south is the Gulf of Guinea, and right on top of it is Burkina Faso. And as you would see here, that is Megan's country. This one is Mali, and they obviously do have a problem there in relation to NCDs. But I show you this so that you realize that we do have an issue. So what are these NCDs, and what does increase in NCDs and prevalence mean for Africa? I'd like to give a brief about NCDs, also known as chronic diseases. Unlike communicable diseases, they are not passed from one person to the other. They are of long duration and generally slow in progression. So the clinical progression and so on are very slow. And there are four main types, largely. Those that are due to cardiovascular diseases, diabetes, in particular, the type 2, chronic respiratory diseases, and of course, the cancers. And to graphically represent these, nearly half of the problems that we have are contributed by cardiovascular disease. And of course, the rest is shared between cancers, respiratory disease, and of course, the other non-communicable diseases. And I show you the growing health problem of this, and I think that, as I say here, the time to postpone the inevitable. We cannot decide to continue to be. It's definitely a health concern, and if you look at the global deaths, okay, there's a clear rise. From 1990 to the projection of 2030, we're somewhere there. So it's contributing to nearly 70% of the global deaths. And of course, if you look at it from the low-income point of view, again, this is what concerns me and in Ghana and of course the others in Sub-Saharan Africa, the projection is even worse. And there are several publications to indicate that South Africa, Africa sub of the Sahara would bear the greater brunt of this emerging epidemic. And this is why I want to show you again the fact that the distribution of the burden of disease as percentage of total daily adjusted life years. So if you look at Africa, this is where we're sitting, okay, and this is from 2000 and of course 2012. So what you're seeing here is the 2012 figures, and Eastern Mediterranean, and of course the rest of this is Europe, and this is America. This concerns you as well. I know that you have taken a lot of actions by way of non-communicable disease. The biggest adult killer in Sub-Saharan Africa in 2010 from the Global Health Report was NCDs. And here I show you the communicable diseases, obviously, have seen, in terms of, this is stratified for age, so from 0 to 4, 5 to 14, of course, 45 plus. And you see that if you look at non-communicable disease, particularly in this group, you see that it's such a big issue. Again, this is from the Global Burden of Disease report. The NCDs account for almost a third of deaths in Sub-Saharan Africa. And here, I show you, again, another graph, yet another one. If you look at the non-communicable diseases here, this is it. It's a big problem for comparing it with the previous one, which I showed you. The top 10 global risk factors ranked by attributable burden to non-communicable disease have been presented. Again, these have been corroborated by studies that Izati and co. and several other people in the field have made contributions to. And again, as you would see here, in this order, you have high blood pressure, tobacco smoking, including secondhand smoke, alcohol use, and so on and so forth. All of these are significant, and of course, what concerns us for those of us in Western Sub-Saharan Africa, of course, this is all Sub-Saharan Africa, and you can make a comparison between Central, Eastern, Southern, and of course, Western Africa. So what is the Ghanaian picture? Here, I show you a picture again from the World Health Statistics 2013, World Health Organization. This is just opposing Africa with Ghana, and here you have the non-communicable diseases. This is Africa. Ghana is not far away from the average. Again, if you look at communicable diseases and then injuries, this is a big concern, particularly for Ghana. This is the probability of dying between age 30 and 70 years from non-communicable disease. And again, I circle that for Ghana, and we are right somewhere there, 15 to 20. This is showing you a shift in the leading causes of burden of disease, again, adjusted for daily adjusted life years. And this is for males in Ghana. And this is presented from 1990 to 2010. And if you keep your eye again on strokes, ischemic heart diseases, cirrhosis, epilepsy, chronic obstructive pulmonary disease or airway disease, and of course low back pain and diabetes, these are an emerging problem. I show you that for the female population, certainly the risk is lower, but if you look at HIV here, within the male population, our pointer is not helping, okay. Within the male population here, and you compare it with the female population, it's not surprising that HIV/AIDS is obviously much more risky in the female population compared with the male population. But of course, when it comes to the NCDs, the male population dominate in NCD. So, what are we doing to tackle the problem? We decided in the last 6 years to look at the whole area of non-communicable diseases. And I'm referring to the Kumasi Center for Collaborative Research. My group in particular decided to look at how can we provide the evidence. Sometimes you have to show policymakers and those who are in health governance the hard evidence, and then say, hey, listen, this is what is happening. We're sitting on an epidemic, an emerging epidemic, and that there's a need to take action. So we decided to take interest in some basic epidemiological studies and to set up cohorts of people living with type 2 diabetes and hypertension. So I have a cohort that has been established the last four years. At the moment, I think we have a population of over 150 newly diagnosed hypertensive and type 2 diabetes patients that we're following for certain clinical outcomes. The other things we've done is to be part of some multinational studies, which I'll be presenting some results to you. We've looked at the area of cervical cancer, and we've also looked at the role that is played by inflammatory biomarkers as far as type 2 diabetes is concerned. And that was just to borrow some ideas that I do in TB, to see whether we will find some issues there and how we can tackle the issues of type 2 diabetes particularly. So we know that, for example, this is a problematic cycle. So you have diabetes there, you have heart disease, you have gastroesophageal reflux disease, acid reflux, high blood pressure, cancer, sleep apnea, and of course, as you can see with this lady, diet, whether she lose weight or diet and so on and so forth is all there. But guess what? The plate is full. It's a mountain full of, and you can see probably sitting there all these sweet stuff that increase obviously your level of calories. Now, so we've prioritized some population-based studies, by way of action. We've tried to understand the health-seeking behavior, and people from here have been part of that effort, including Megan. We've tried to generate data to increase understanding of various factors that play a role, particularly those of inflammatory biomarkers, to look at, the population level. We've looked at population genomics of type 2 diabetes as well, and to look at some genetic factors, and to understand, because, there's some areas, I can tell you for a fact that, some rural areas in Ghana, for example, would have hypertension as the number 2 cause of morbidity. And these are rural areas. And yet you can have a similar picture in an urban area. And therefore, it tells you that there are several drivers, of the cause of some of these non-communicable diseases. And therefore, it's not everything that we do understand. And we decided to study some of these things to provide the evidence. Additionally, we've looked at the generation of primary and secondary preventive methods. So, for example, 3 years ago, was it, when Beth and as we got together to say, hey, how can we, develop interventions in appropriate point of care diagnostics for type 2 diabetes, for example. And the team here in Pennsylvania, University of Pennsylvania, is working on this. And of course, we've looked at strengthening peripheral health services, to deliver health care so as to reduce congestion at tertiary health institutions, particularly for those suffering from non-communicable diseases. And we've looked at inclusion of chronic disease management in development activities. I have to say that with all of this in the background, the budget by way of health policy is hugely insignificant. And therefore, those of us in research have had to consider, other means by which, we can provide, as it were, to back up what is going on. So by way of policy, there have been changes, in terms of surveillance data. There've been, for example, we've introduced vaccines, for girls in school, to fight against cervical cancer and so on and so forth. We're still analyzing some of the data. We've tried to adapt some of the best practices models from other African countries. South Africa, for example, has shown leadership in many of these interventions, and we're seeing, why not? Some of them you may not have to reinvent the wheel. You may have to just look at what the evidence says, and then, of course, you can initiate some of those policies. But in addition to all of this, we decided to conceptualize an idea. So a group of us Ghanaians, some of whom live in London, in Amsterdam, in Berlin, decided to come up with an idea. And the basic question was, does migration play a role in the development of non-communicable disease? In this case, we're talking about type 2 diabetes. So because we thought that, if we studied Ghanaians in rural Ghana and compared them with their counterparts in urban Ghana, and then looked at same Ghanaian population, not same, but similar Ghanaian populations from within, Amsterdam, Berlin, and London, and we compared certain environmental factors, and of course some, other factors. Would we see a change? And has migration significantly affected this population over time? And therefore, we came up with this RODAM study, which RODAM stands for Risk of Obesity and Diabetes Among Migrant Population. Risk of Obesity and Diabetes Among Migrant Population Study. And again, I'm repeating the point that, it's projected that in 2030, 35, 55% of the world's population will be suffering from non-communicable diseases. It's a huge menace, particularly type 2 diabetes. 77% of people with diabetes will live in low and middle income countries. And that for us is worrisome. It's such a gloomy picture, of the numbers. Proportion of diabetes from 20 to 79 years that are undiagnosed in 2013. And that is a big problem, and here I'm concerned about 48, nearly half of the burden are undiagnosed in certainly Sub-Saharan Africa. So, and of course, diabetes reflects on cardiovascular diseases. Trends in stroke. Here I present trends in stroke mortality in England and Wales for selected migrant groups, aged 30 to 69 years. Ratios, 95% confidence interval in this. And this is for males, and this is for females. And so you can look at, for example, West Africa. There's nothing. You can look at East Africa, and you can compare that with, for example, Republic of Ireland, and of course, that of Italy. It's significant to realize here that those from Jamaica among women, you can look at the same. Here for the male population, we have some data to show from West Africa. It's huge. It's a very huge problem. It's among, you can compare those of Bangladesh with those of males in West Africa, and that is a very, very worrisome picture. Again, the problem is not just seen in the health indicators, but also in the financial burden. The contribution, the amount of money that goes into managing type 2 diabetes and non-communicable diseases. And guess what? In Africa, north of Sahara, it's something around 14 billion. If you come to Sub-Saharan Africa, it's around 4 billion. And largely that's because the governments of Africa have realized that if they have to go in and do active case search of disease like type 2 diabetes and so on, it will be a tall order, in trying to manage these. Because, we're not out of the woods yet with communicable diseases. And therefore, if you have to go head on with these, it's going to be a huge problem. And I dare say that the figure here is a reflection of the lack of inertia into taking on board a huge burden, of those undetected cases in Africa. And of course, that's a significant figure. $4 billion in expenditure is a very significant figure. I've repeated this. So there's also a disproportionate affection of ethnic minority groups and migrants in Europe that have been particularly affected with this type 2 diabetes. And again, as I say, is it nature or is it nature? Food or nature? And of course, there is an intersection. We are not clear. There have been several studies to showcase the contribution of genetic risks and some of the genetic risk factors. We know about obesity, diabetes, and obesity and the relationship that has been established. There have been theories of environmental risk, including the hygiene hypothesis, and so on and so forth. There have been several theories, but is there an intersection? Do we know all of it? We don't. So we conceptualized this, and we thought about all of these. So rural, urban Africa, okay, rural, urban Africa, and that obviously refers to rural and urban Ghana. And then we looked at the genetics arm. We wanted to look at lifestyle factors such as diet, alcohol, physical activity, smoking, and so on. Wanted to look at healthcare, biochemical factors, including inflammation, physical and psychosocial factors, and then epigenetic factors, which of course is a relatively new area. At what point in time within the environment do we have a trigger within the cell that causes or would predispose somebody to the development of type 2 diabetes? And that obviously is the field of epigenetics. And of course, we wanted to look at life experiences, malnutrition, disease, and so on and so forth. And of course, the differences in risk of obesity and diabetes was the outcome variable of interest. So this was the conceptual model of the Rodham study. And we wanted to look at this from the rural point of view, compared with the urban point of view, and then, of course, that of a developed, as it were, westernized exposure of Ghanaians, to that environment. So again, as I was mentioning, there have been several evidence, by way of the environment. The importance of environmental exposures are well demonstrated and documented. They are known risk factors. They don't explain the ethnic differences, I have to say. Okay, there are genetic factors that do explain. Some studies have shown, genetic factors that do explain some of the ethnic differences. So, for example, I present here data of Bendraban and co. From BMC Public Health in 2008, where they showcase, for example, ethnicity. So Hindustani, African, and White Dutch. And you can look and see that clearly the risk is higher in the Hindustani population. And of course, in genetics, there have been several studies, GWAS, several genes have been associated with type 2 diabetes and obesity. So for example, FTO, TCFL7, and L2 genes, the contribution of genetics vary. And but of course, the last point which I want to talk about is lifestyle factors in relation to, for example, the sizes of our usual friend here, and it's emerging in Africa. Epigenetics, countless gene-environmental interactions between gene and the environment and the triggers thereof. And there have been several, documentations, at the chromosomal level, and several theories in relation to several diseases, and in particular, the disease of concern, type 2 diabetes, to show that there might be some triggering factors of epigenetics that may be related to type 2 diabetes. So we wanted to understand the gene environment. We wanted to look at the interaction. We wanted to identify the relevant risk factors and to guide intervention programs. The other thing we wanted to do was to provide basis for improving diagnosis and treatment. I mentioned to you earlier that nearly half of the population are missed. And of course, specifically, we wanted to look at the differences in type 2 diabetes and obesity among Ghanaian migrants living in different European countries, of course, and to identify the relevant epigenetic, biochemical, environmental factors and their relative contributions to type 2 diabetes, and of course, explore presence of interactions between genetic and lifestyle factors. So I mentioned to you that so that's Ghana. The participating countries are Ghana, and of course, those are interesting scenes from Ghana. Okay. I'm not sure, Megan. Did you ever go to Kakum National Park? Mm-hmm. Okay, it looks like that. And then that's the Kwame Nkrumah Mausoleum. And Amsterdam is the other country from the north. Then, of course, we had the United Kingdom, Great Britain, and, of course, Germany. And we sampled Ghanaians from Berlin in Germany, Amsterdam in the Netherlands, and, of course, London in the United Kingdom to understand what may be going on in these populations. And, of course, for each population, we had 100,250 per population. So in Ghana, we had a two-stage cluster randomized sampling design, which involved the smallest administrative unit. We call that the enumeration areas. So we selected from both urban and rural. And of course, in other sites in Amsterdam, they use a resident Ghanaian city list. Well, the downside of that is that there might be some illegal migrants that may be missed in the population. So there was a combination of a snowballing approach to the typical, randomization design in some of these. And this is a process of sampling. So essentially, we go to the communities, we do the announcement. Before we go, of course, we load our cars. If there was a mobile clinic, we go to these communities. we go there, we do the announcement, inform them about the study, and typically you have to talk to the village head, beat a gong, and interact with them and say this is what you're doing, and seek their consent. And then after that, you interact with the people. So we do a mini census, and of course we take a random sample from the population, and then we interview them. It was a very long interview process. Some of the data collection instruments could last for about an hour, and there were 3 or 4 of them. So, and in total, I think we spent close to 2 hours with one patient. And after that, you have to take fasting blood sugar, you have to take body fat impedances, you have to take their mid upper arm circumferences, sitting height, standing height, blood pressure, and all those anthropometric measures. And here you see interviews being conducted there. And of course, these are the clinic setting. We usually would work with the district health administration. So we set up a clinic there, and then the population will come over, and then we would take the blood sample and of course analyze their sugar and sugar from their urine, and of course also from their blood. And there were several other parameters that we looked at. So many of them. So demographic, age, sex, marital status, socioeconomic status, lifestyle, blood pressure, ankle arm index, biochemical parameters, so hemoglobin A1C, insulin, lipid profile, liver enzymes. These were all done. Electrolytes, DNA samples were also taken for the epigenetic studies that we conducted. So these are, I apologize for this dense slide, but I thought it was important to show you that in the end, the demographic characteristics of the Ghanaian population, we exceeded our sample size. It was largely a female population. In the end, it was skewed towards a more feminine population. And they, as you can see from here, it's just a preliminary description of the population at the time, a total of 1,714. I have to say that these are early days yet, in terms of the numbers. We will have to conduct a more robust analysis. But from the various sites, so from Ghana, we had nearly 1,500. And then, of course, in Berlin, they had the smallest. And in Amsterdam, they had nearly 1,900. And then, of course, in rural Ghana, we had 1,100 people. And this is shown graphically here on the right. This shows the age standardized prevalence of diabetes using the WHO criteria by locality for the various places. And clearly, you would see that in Berlin, they had the highest among men. In Berlin, they had the highest in terms of the prevalence of diabetes. This was also significant, again, in the female population, again, by locality. So here, in the male population in rural Ghana, you had something like 1.4, and then, of course, compared with that of Berlin, it was a significant, huge difference. This is the age standardized prevalence of diabetes. This is using the American Diabetic Association criteria by locality. And again, you see that whereas in the women population, there was not much significant difference between the Amsterdam population and the Berlin population, it was hugely significant here within the male population. Now, when you adjust the prevalence ratios of diabetic by criteria and locality against sex, this is what you find. And you have the WHO criteria there within men. And of course, that for women is the one down there, and followed by the American Diabetic Association criteria for both men and women. Again, I show here the age-adjusted predicted probability of diabetes by age and locality. And again, as you would see here, the topmost here, the slide, is the Berlin. And this is for men, and this is for women. And here, Amsterdam appears to be doing, among the women population, to be doing higher compared with that of rural Ghana. This is the age standardized prevalence of prediabetes status that's referring to impaired fasting glucose by locality. And here you see that as far as impaired glucose is concerned, the Ghanaians in Amsterdam, there's definitely something going on there that requires us to investigate. It's the same for both men and women. Here I present this in another form, showing the probability and the 95% confidence interval for all locations. Again, I present here the age standardized prevalence of generalized BMI, obesity, by locality. And as you would see, London is performing the worst, particularly among ladies in London. And that, again, one has to go there and find out what is going on there. But certainly, as you would imagine, the Ghanaian population. But what is significant that has to be said is that you see that urban Ghana among women is definitely comparable to some of the developed countries in the Western world. Again, age standardized prevalence of abdominal girth, by locality indicates that, certainly there is a very remarkable, the women are doing something that we need to understand by way of the abdominal girth. And of course, we do know that obesity is a precursor or a risk factor for type 2 diabetes. Again, here I show the odds ratios of the same that I showed earlier. And in this, I give an age-adjusted predicted probability of diabetes by BMI in men by locality. And again, you see that this is the Berlin group sitting right here on top for the men. And there you have, the Berlin group sitting right on top. So it looks like men and women in Berlin must be doing something that we need to appreciate. Again, here is the age-adjusted predicted probability of diabetes by BMI in men by locality. And here you see, again, Berlin outperforming everybody else. Here, this is the waist circumference by locality for men. And I have to say there's a massive, significant difference between that of women, the mean waist circumference between that of men and women in Ghana. It doesn't matter where they live, there was quite a huge difference. Again, age-adjusted predictive probability of diabetes by waist circumference by locality in women. Again, here you see Berlin sitting there, and similarly there. So, what are some of the findings that we found? Diabetes is a major problem among Ghanaian migrants in Europe. That's a fact. Again, we have seen that urban Ghanaians have also affected and are, in some instances, at par with some of the risk factors with their Ghanaian migrant counterparts living in developed countries. The differences are more apparent at the older age, and we're yet to present the results. Is being analyzed. As you would appreciate, the epigenetic data takes time, so we don't have preliminary data yet to share with you, but I promise that when we do have it, we will share some of these data with the reading world. And of course, prediabetes is a more problematic issue among Ghanaians in Amsterdam. And as I said, one requires to look into that. And that has to relate with diabetes. When it comes to obesity, it's highly problematic, obviously, among Ghanaian migrants. But urban Ghanaian women has also been particularly affected. And of course, there are significant impacts when it comes to the BMI levels, comparing those of Berlin and the rest of our studies. There is an interaction between globalization, the risk of HIV and TB infection. And of course, this could potentially lead to what we refer to as the obesogenic environment. And there's more to understand, but whereas there's more to understand, Africa has been hit by this, and I think we need to sit up to look at providing the evidence and tackling the issue. This interaction inadvertently leads to a risk of non-communicable disease, and in particular type 2 diabetes in this case. And although the rising incidence of non-communicable disease in Sub-Saharan Africa is aggravating the communicable diseases, I want to say that there are well-meaning research groups that are looking at tackling the issue, providing the evidence, and best practices to be borrowed from elsewhere, so that we can deal with this growing menace. And on that note, I would like to pay a glowing tribute to our partners. Source Bioscience, they are handling the epigenetic data. And of course, the nutrition data is all being handled by our team in Germany. There are two of them, Charité and of course Potsdam. And of course, KNUST, where I belong. And of course, the London School of Hygiene and Tropical Medicine. They contributed to the recruitment and of course the analysis of data from London. And of course, we have RIPS, which is the Regional Institute for Population Studies based in Accra. And finally, the International Diabetes Federation is also on board. Actually, the chairman is one of the investigating scientists within the research team. And on that note, I'd like to say thank you for your attention. And I want to show you our wonderful team there in KCCR. For those of you who have visited and for those of you who are yet to visit, we are a very charming, smiling population. Thank you very much. I'll take questions now. Yes.
One thing we're seeing here in Philadelphia is a lot of our new sort of TB cases from coming late TB reactivating in our new diabetics. So I was curious if you're starting to see that trend of reactivation in your sort of older population.
There's an established fact. Now our group has shown that. I mean, there's nearly fourfold risk of persons with TB in developing type 2 diabetes, and several others have shown this. In many earlier, I think we were in denial because the evidence was not tipping. Of course, all of these you have to look at the systematic review and showcase what the evidence shows. But yes, there's a clear picture also in Ghana and several other places in Sub-Saharan Africa, and I can understand that from the point of view of migrant population. I have to say that in many Western populations, the issue of TB has been as a consequence of people migrating from developing countries to developed countries, and they have contributed significantly to the huge numbers of tuberculosis and consequently some numbers in type 2 diabetes. Not to say though that number is significant. There's a huge population of people in-house or in-country who do have type 2 diabetes originally, but within this migrant population, there's a significant association between type 2 diabetes and tuberculosis. Yes?
Very quite alarming. Plays out in most countries.
Mm-hmm.
A study we did in Nairobi showed that a quarter of all hospital admissions were related to complications of diabetes. The country that taught the world how to run, if they're having a problem with diabetes, it's very alarming. I was curious, have you been able to track the internal migration from rural to opera, for example? And I realize that requires a lot of granularity and it's longitudinal, but that could be a very telling statistic right there. While it gets very difficult to measure for those Ghanaians who migrate to Europe, do you profile changes in mood disorders or depression, and might people be self-medicating with alcohol and food to treat their depression because they don't have access to other means of alleviating that?
Thank you very much. Your question is about migration and the development of type 2 diabetes, and as well as the use of self-medication, particularly people suffering from depression and the consequence of diabetes. I have to say though that I do have anecdotal evidence when it has to do with movements. There's very little when it comes to documentation, but we do have. So for example, in Ghana, you typically would have the northern population moving down south, and largely it's because of economic reasons. And one has to find out and document this within the migrant population and find out what is actually happening. But we are aware that when they move south, their wealth quintiles appear to increase. There's evidence to show that their wealth quintiles increase. What we do not know is to what extent other factors would contribute to by way of the development of type 2 diabetes, for example. And that is something that maybe Megan has to come back to Ghana and look at. But on a more serious note, I think it's something worth considering. And I probably would be thinking about this and getting an MPA student, to look at this and document this for sure. The other area of use of self-medication, and certainly we're all aware that mental health is projected to be only second to ischemic heart disease in the next 20-25 years. And is the same thing in Ghana. Actually, we are beginning to see increased numbers, in terms of depression and so on and so forth. But what I do not know is to what extent is self-medication and the use of antipsychotics a contributory factor, and all resorting to abnormal eating as a contributory factor in type 2 diabetes. And I think, again, that is an area worth looking at. I probably have to update myself by way of literature in other countries, and then we can borrow the ideas and the methodologies and replicate some of these ideas in Ghana. I think it's interesting. Thank you. Yes, Dave.
Ghanaian population in, say, London, are there significant differences between them and people who are non-Ghanaian in England? Or are there?
We did not look at the non-Ghanaian population. We were basically interested in the Ghanaian population, and we got 3 million euros to do this within 3 years. It was a huge task, but I guess the next step, we've actually submitted another. It was from the EU. It was the FP7 call, the Framework Program 7, and we're looking forward to getting additional funding to extrapolate this. But they've been minor. People have studied minority populations in these settings, in small population studies. And there are also, for example, studies in the Surinamese population and those from Eastern Africa and from Southern Africa and so on. I think it's about time to start pulling all of these data together, and we are in the process. I have to say, those of you who are interested, I think Izati and co, we contributed data to this, have published the trends in, for example, life expectancy in relation to non-communicable disease and cardiovascular disease in the last 2 months. There's yet another paper about gain in height of people living in Sub-Saharan Africa in relation to the rest of the world. And we're coming up with more of these things. And I guess, again, as you know, it takes time and money. But we will get there. We'll start providing the evidence and we'll see. Yes?
Did you see any significant differences within a certain rural population between the younger age group and the older age group with regards to incidence?
So what is clear from our data is the fact that the adult population, and by the way, we studied people aged 25 and above, 25 to 75 years. We are aware that those who are 40 and above have or did have the significant highest risk in pretty much all the indicators. Now, I don't know what you mean by younger, because 25 for me, well, unless you're referring from 25 to 30 or 25 to say, I don't know, 35, their risk was significantly lower compared with those who were above 45 years of age. But we did not study those below 25 years. Okay, so those in the adult population beyond 40, 45 had a significantly higher risk in nearly all the indicators. We're yet to analyze the epigenetic data, but of course that looks at the cellular level and the triggers, and we'll provide the evidence later. Yes, Glenn.
Yes, I apologize because I'm trying to find out where the food is, and I didn't hear the last question, so I hope I'm not repeating it.
It's all right.
On the topic of food, yeah.
Food and diabetes.
So obviously, many migrant populations migrate in familial clusters, and I'm wondering if in your surveys you did any familial mapping, and therefore might have some clues to whether, I think that would maybe give you clues to genetic components before you're actually able to do sequence analysis.
Thank you. So I haven't told you the full story. So we have 2 PhD students, one in Amsterdam, one in London, that is looking at a disaggregated data on the basis of ethnicity. And they're going to be presenting us with spatial analysis of clustering in terms of what the triggers, particularly in reference to the epigenetic data, might be. That is ongoing, and we're proud to say that there's several, as many as the last count, as many as 12 PhDs, on this program, which is really great, from all these sites that I mentioned. So that is in development. Thank you. Yes. No, I believe your question is to know whether there were some significant clinical endpoints in relation to complications of diabetes. No, this was cross-sectional, and we did not look at the clinical outcomes. That is for another day. And I can tell you that my group is looking at, in this cohort study that I told you about, we are looking at what are some of the endpoints, and what times do these endpoints, happen in a significant at the population level, and within which age populations, and is there a role for comorbidities, for example? I mean, if somebody has HIV and has type 2 diabetes, somebody has this and that in combination, what are the significant risk factors in terms of the endpoints, such as development of cerebrovascular accidents and the other things, cardiovascular disease and so on and so forth. And all these are being looked at from another point of view. So this was cross-sectional. It was just to look at some of these at the cross-sectional point of view, and then we can take this from a more longitudinal, point of view, to which you can better describe the incidence rate and, of course, the risk factors. And that's what we're doing as a supplement to the original idea. Yes.
Ghana's making great progress with universal health care.
Mm.
The sponsors or government organizations, are they current with the work that you're doing and looking at the actuarial impact of non-communicable disease on universal health care? And if they're not, could you use some help from the work?
Thank you. I believe your question is whether government is in concert, and whether they are in real time they're agreeing with what we're doing. The simple answer is no. We definitely are miles ahead by way of research, and of course the evidence we're providing in the interventions. It resonates very well with other research organizations and institutions from across the globe. I have to be sure, but I can tell you that there's a paltry, insignificant figure in terms of funding for non-communicable diseases. The reasons, we do understand some of it, but some of it we do not understand. That if you have a country where in nearly all the urban centers, the number one cause of mortality in all the teaching hospitals is a cerebrovascular accident, strokes. So that tells you something. So question is, must one wait? Must one wait until, we have all the money spent on rehab, this huge population that may be suffering from the consequences of ill management of hypertension, for example? And there are more issues. I mean, quality of medicines, for example, access, harmonization of the interventions. These are issues that one has to look at. So it's multifaceted, and I think the simple answer is that the governments are completely. I can tell you there's a skeletal staff at the Department of Non-Communicable Diseases at the Health Ministry level. Where you can number them, I think 3 or 4 people, and it tells you the commitment by way of both money and personnel, and it's just not there. We do have a huge issue. We're hoping that as we keep providing, we seem to be doing well in many fronts, by way of numbers. But I don't like us to compare ourselves with the rest of Sub-Saharan Africa. I think good thing is to to try and see how well you're faring with, compatriots who are doing better in terms of interventions and controlling these menaces. And I think on that front, I wouldn't say that we're doing well. You're welcome.
Questions? Thank you, Ellis.
Thank you.